colleague of mine was looking for the School of Animal Neurology. So I directed him to the hippocampus. And have you wondered why nerves are just so reckless, man? Because they do everything on impulse. Hello everybody, it's Dr. Ryan here. I hope you and your folks are well. Today we're addressing multiple sclerosis. I strongly encourage you to smash that subscribe, like, and share button. This is the outline of our talk, guys. We're going to be addressing a clinical case just for some context behind the condition, and as customarily the case in these talks on my channel, we're going to split this 7 ways, talking about an introduction, and then we're going to look into etiologies behind MS, take a closer look at how patients present, look at a plausible differential diagnosis for our signs and symptoms, look at diagnostic evaluation and investigative workup, treatment and management modalities, prognostication and complications, and then we're going to summarize our key points. Then we're going to look at encouragement from scripture. God bless you. Thank you so much for joining me, everybody. Let's get stuck in. Let me just get my pen in there. So we've got a 38-year-old woman today who has the relapsing, remitting form of multiple sclerosis. Now, she has experienced 2 attacks of the disease previously that have left her with a residual lower extremity weakness. She was initially treated with glucocorticoids with some degree of improvement in her symptoms. However, she is currently only able to walk with a rolling walker, only about 100 meters. A prior antibody test shows that she is positive for reactivity to the JC virus. You are planning to start a disease-modifying therapy. Which of the following is the least appropriate for this individual? Is it A, dimethyl fumarate, DMF? Is it B, interferon beta-1 alpha? Is it fungolimod, natalizumab, or teriflunomide? Let's get into it, guys. So, multiple sclerosis, MS, is an acquired demyelinating disease of young adults that tends to follow a relapsing remitting course with variable degrees of disability. Now, MS causes demyelination and sclerosis, those are the buzzwords, of brain, spinal cord, or both. The location of the damaged myelin lesions is the major factor which determines your symptoms and disability. It is the most common autoimmune inflammatory disease of the central nervous system. Now, patients may experience one of 4 clinical courses that can be mild, moderate, or severe. So there's 4 flavors, right? The relapsing remitting form, which is most common, has the best prognosis overall. Then there's the primary progressive, the secondary progressive, and then the progressive relapsing. All right, so let's look at etiology, epidemiology, and risk factors, guys. So it is presumed to be an autoimmune process. Now, some evidence suggests that the disease is contracted in early life whenever we have a viral immunogen which stimulates the immune system, which then results in complex B and T cell dysregulation. It affects the central nervous system and our beloved optic nerves. Destruction of the myelin sheaths results in demyelination and inflammation of the white matter in the central nervous system, right? The tracts, the white matter. Multiple plaques of demyelination of different ages and in different locations are seen. So the clinical maxim when you're thinking about multiple sclerosis is that you have a variety of different lesions in the central nervous system which are separated by time and space. Separated by both time and space, which speaks to the different ages and the different locations of the demyelinated lesions in the CNS. It's a disease of unknown etiology, probably by an autoimmune process underlying it that occurs in genetically susceptible persons. Familial incidence is about 15%, suggesting some kind of infectious etiology. Now, there are certain histocompatibility antigens in patients with MS, which does allude to there being a genetic predisposition, all right? The peak onset is from ages 20 to 40, so yeah, the youngsters, and rarely occurs after 50. There's a rising incidence with rising altitude. So whereas we have incidence of less than 1 per million at the equator, the incidence is much higher in the northern states at about 80 per million, example in the States and in Canada. Studies have suggested an association with smoking. Okay, so this is a beautiful diagram taken from Harrison's, right? Oh dear. Let's just get my pen in there, which demonstrates for us nerve conduction in myelinated and non-myelinated or demyelinated axons. So here we can see that there's nodes of Ranvier between the myelin sheets of the neuron, right? And conduction occurs by what we call saltatory nerve impulse conduction, in that the action potential jumps from one node to the next node. Saltatory conduction, which is much more efficient and much quicker, right? The sodium channels, which are shown as breaks in the solid black line, these are sodium channels, right, are concentrated at the nodes where axonal depolarization occurs, versus the situation in a demyelinated nerve axon, where additional sodium channels, yeah, are redistributed along the axon itself. So whereas in the myelinated axons, right, these sodium channels are just kind of concentrated at the nodes of Ranvier, here they have to be located all throughout the axon itself, thereby allowing continuous propagation of the nerve action potential despite the absence of myelin. Okay. Guys, how do patients with MS present? Presentation excuse me, and symptoms depend on the area of the central nervous system that's affected. So optic neuritis with visual loss is probably the most common manifestation. Some of the patients complain of something called Lemaitre sign, which speaks to myelitis, so spinal cord affectation. They actually sense some electricity going down the back upon passive flexion of the neck. Right, brainstem and cerebellar dysfunction manifests as diplopia, ataxia, dysarthria, and dysmetria. Right, so past pointing. Weakness, we give you monoparesis, hemiparesis, or paraparesis, right? Any of that, depending on the area of the CNS which is affected. Sensory symptoms may include a sensory level in spinal cord disease, right? Bladder and bowel dysfunction. Psychiatric features include depression and cognitive complaints. You may also have a Marcus gun pupil, ophthalmoplegia, or upper motor neuron signs like Babinski or hyperreflexia. Remember that you have different lesions manifesting at different times. So once again, the clinical maxim is different neurological lesions separated by time and space, right? Okay, this is the symptoms of MS in another format from Harrison's. So you got the symptom percentage of cases. Sensory loss in 37%, optic neuritis 36%, so probably the most common, right? Weakness in 35%, paresthesias in 24%, diplopia 15%, ataxia 11%. And it's somewhat less common are vertigo, paroxysmal attacks, bladder and bowel dysfunction, Lemaitre sign, pain, dementia, visual loss. So even though 36% get visual loss, only about about 36% get optic neuritis, only about 2% end up with visual loss. Facial palsy, impotence, myokymia, epilepsy falling as well, albeit somewhat less common. So this is the diagrammatic representation of the different clinical forms of multiple sclerosis. So in image A, we have the relapsing form. So we have a variety of different lesions in the central nervous system separated by time and space, as depicted here. In B, what we have is a secondary progressive form, right? So you have some lesions separated by time and space, and then we've got a continuous kind of progression thereafter. It's called secondary progressive. And C is primary progressive, where there's no separation of the lesions. It's just progression from one to the next and an increase in severity. Okay, so a nice way to remember the clinical manifestations of multiple sclerosis is elementary, dear Watson. Elementary. Right, so Watson. W stands for weakness. A is for ataxia. T is for tremor. S speaks for speech in the way of scanning speech, alluding to cerebellar etiology. O is for optic neuritis with subsequent visual loss thereafter. And N is for nystagmus. So it's elementary, dear Watson. Nice one. Here's a fun diagram illustrating the features of multiple sclerosis from medcomic.com. Thank you, Mr. Jorge Muniz and company. Let's get my pen in there. So, we said multiple sclerosis is an immune-mediated inflammatory demyelinating, nice words, of the central nervous system. It results in clumsiness and muscle weakness and a variety of pins and needles, you can see, which speaks to paresthesia. Optic neuritis, right, so that leads to blindness. Lemaitre sign, which is that electrical sensation going down the back on flexion of the neck, right? Then we got onset at between 15 and 50, and treatment options include corticosteroids, beta interferons, 1 alpha, 1 beta, and glatiramer acetate. Okay, very nice annotation. Thank you so much, guys. What's a plausible differential if you think your patient may have MS? So it can be ADEM, which is acute disseminated encephalomyelitis. Other demyelinating syndromes, example, central pontine myelinolysis, which happens in the setting of correction of your electrolytes, notably hyponatremia. If you correct it too quickly, you end up with osmotic demyelination syndromes. DeVick's disease, which is otherwise called neuromyelitis optica. Then we've got autoimmune disorders, the likes of systemic lupus erythematosus, the Wolf, vasculitis, antiphospholipid antibody syndrome, sarcoidosis. Neoplastic and paraneoplastic syndromes, especially lymphoma. We have gliomatosis cerebri, adrenal leukodystrophy, metachromatic leukodystrophy, HIV encephalopathy, and B12 deficiency. B12 deficiency gives you subacute combined degeneration of the spinal cord. All right, and we're all familiar with those deals right there. Okay, disorders that can mimic multiple sclerosis. It looks like, smells like, quacks like MS, but it's not MS, right? So we already been through these. We spoke about ADEM and antiphospholipid and Behçet's, and CADASIL is cerebral autosomal dominant arteriopathy, subcortical infarcts, and leukoencephalopathy, leukodystrophies, HIV, ischemic optic neuropathy, Lyme disease, right? The list goes on. We spoke about Divix disease, Sjogren's syndrome, syphilis, SLE, tropical spastic paraparesis, which is caused by HTLV1 or 2, vasculitis and B12 deficiency, and SCID. We spoke about that, right? Okay, so guys, how do you evaluate a patient diagnostically? History and physical exam, the basic tenets of medicine, right? And axillary tests determine the likelihood of disease as being either clinically definite, lab supported definite, clinically probable, or lab supported probable, right? So remember, there are 4 clinical flavors of MS. Now there are 4 kind of diagnostic possibilities here. The MRI, as we know, is the most sensitive test. It will demonstrate for you beautiful multiple white matter abnormalities in the periventricular locations, posterior fossa, and spinal cord. Okay. For patients with classic demyelinating lesions on MRI, minimal additional workup is required because you clinch the diagnosis there. You've got clinical, you've got imaging features. Multifocal demyelinating lesions separated in space and time, that's what we said is the clinical maxim, are classic. Small vessel ischemic disease can be mistaken as demyelinating lesions. MRI essentially always shows lesions. If absent, you should really reconsider the diagnosis. In patients with optic neuritis, if MRI reveals typical lesions of MS, the full disease will likely develop, okay? CSF analysis reveals our beloved oligoclonal bands and increased immunoglobulin G. Mild lymphocytic precytosis and acute attacks on protein may be slightly elevated. You may also have slow evoked potentials on NCS, which is visual, auditory, and sensory, okay? So this is looking at the diagnostic criteria for multiple sclerosis. So let's just have a quick squiz at this. This is taken from Harrison's. So we've got clinical presentation and any additional data. So if we've got 2 or more attacks with objective clinical evidence of 2 or more lesions, or objective clinical evidence of 1 lesion with reasonable history, then you don't need any other additional data. But if you've got 2 or more attacks with objective clinical evidence of 1 lesion, which is disseminated in space, demonstrated by more than 1 T2 lesion on MRI in at least 2 out of 4 MS typical regions of the CNS, which we mentioned being the periventricular, juxtacortical, infratentorial, or spinal cord, or you need to await a further clinical attack implicating a different CNS site. If you've got 1 attack with objective clinical evidence or 2 or more lesions, additional data as they must be disseminated in time, demonstrated by the simultaneous presence of asymptomatic gadolinium-enhancing and non-enhancing lesions at any time, or a new T2 or gadolinium-enhanced lesion on follow-up MRI, irrespective of its timing, with reference to a baseline scan, or await a second clinical attack. If you have 1 attack, right, with clinical evidence of 1 lesion clinically isolated, then you need dissemination in space and time demonstrated by imaging, or you need to await a second clinical attack implicating a different CNS site, or you look for dissemination in time when the simultaneous presence of asymptomatic enhancing lesion, or a new T2 or gadolinium enhancing MRI lesion, irrespective of its timing, or await a second clinical attack. If you got the insidious neurological progression suggestive of multiple sclerosis, which is primarily progressive, then you need, in addition to that, at least 1 year of disease progression, retrospectively or prospectively determined, and you need 2 out of 3 following criteria: evidence of a typical lesion on MRI, positive CSF, and evidence of dissemination in space. These are typical sites for a demyelination in multiple sclerosis, as we see on gadolinium-enhanced MRI. In image A, we see an axial first echo image from a T2 weighted sequence that demonstrates multiple bright signal abnormalities in the white matter, as we see by the arrowheads, typical for MS. In B, we see a sagittal T2 weighted fluid attenuated flare, fluid attenuated inversion, recovery image in which the high signal of the CSF has been suppressed. CSF appears dark, whereas areas of brain edema or demyelination appear high in the signal, right, as shown here in the corpus callosum. So we see these white areas lighting up there. Lesions in the anterior corpus callosum are frequent in MS and rare in vascular disease. In image C, we see a sagittal T2 weighted fast spin echo image of the thoracic spine demonstrating a fusiform high signal intensity lesion in the mid-thoracic spinal cord. There we go. right? And indeed, there's a sagittal T1 weighted image obtained after the IV administration of gadolinium, revealing focal areas of blood-brain disruption identified as high signal intensity arrows. There we go. Alrighty. Guys, how do we treat multiple sclerosis? There is no cure, unfortunately, but existing therapies have demonstrated promising results. Steroids are indicated for acute attacks, high-dose IV steroids for moderate to severe attacks, immunomodulators in the way of interferons, glatiramer acetate for prophylaxis of relapsing events. Consider intravenous immunoglobulin or plasmapheresis if the attacks are unusually severe. Consider immunosuppressive agents and chemotherapy for unusually severe cases. Right, you're also the new kids in the block on itolizumab and fingolimod. Supportive care includes physical therapy, prosthesis or orthotics, amantadine to reduce fatigue, antispasmodics like baclofen, antidepressants, bladder dysfunction agents like oxybutynin, analgesia. Right. For spasticity, we can advise stretching exercises, refer to a physiotherapist, medications in the way of baclofen, tizanidine, gabapentin, diazepam. For the fatigue, we talk about lifestyle adjustments, education to avoid heat. You want to exercise, and medications we can use is amantadine, modafinil, and methylphenidate, right, which will stimulate them. For depression, refer for counseling. You can use antidepressants like amitriptyline, fluoxetine. For cognitive dysfunction, the use of memory aids and a trial of cholinesterase inhibitors like our good friend donepezil. All right, let's talk about prognosis and complications, guys. The clinical course is marked by exacerbations and remissions, So the relapsing remitting form, here the episodes are acute, but they tend to show good recovery. In secondary progressive, there's gradual deterioration with superimposed relapses. In primary progressive, there's just a gradual deterioration from the outset. And in progressive relapsing, there's gradual deterioration from the onset with relapses superimposed. Factors which are predictive but are weak but identifiable include a worse prognosis in males, a later onset of disease, a progressive form from the onset, motor symptoms from the onset, and poor recovery from first attack. Alrighty. MRI is weakly predictive with a higher lesion load suggestive of a worse prognosis. Patients who do well in the first 5 years tend to do well for the next 5 to 10 years or longer. So it's promising if you do well initially. Those who do well for the first 10 years have a 90% chance of doing well for another 10 years. 50% of patients with optic neuritis will go on to develop multiple sclerosis, okay? Alrighty guys, so coming back to our clinical case, we had a 38-year-old woman who had the relapsing remitting form of MS. She experienced 2 attacks of disease prior, and now she has residual low extremity weakness, quite debilitating, was treated with steroids with some improvement. Prior antibody test shows she is positive for the JC virus. You want to start disease-modifying therapy, which is the least appropriate for her, and the answer will be natalizumab, right? So over the past decade, 10 disease-modifying agents for the treatment of MS have been approved. Due to these multiple options, it is preferred that if you have a patient in whom you suspect MS, you refer to a treatment center who has experience in treating the disease, often neurologists there. JC virus is implicated in the development of progressive multifocal leukoencephalopathy. This life-threatening condition occurs in 0.3% of all patients treated with natalizumab and in about 0.6% of patients who are positive for JC virus antibody. The risk is lower in the first year of treatment and increased thereafter. Thus, natalizumab should not be used in this patient unless she has failed alternative therapies or if the disease course has been particularly aggressive. Right. Guys, key points about MS once more, just to wrap up. Multiple sclerosis is characterized by disseminated patches of demyelination in the brain and spinal cord. Common symptoms include visual and oculomotor abnormalities, paresthesias, weakness, spasticity, urinary dysfunction, mild cognitive symptoms. Typically, neurological deficits are multiple, with remissions and exacerbations gradually producing disability. Diagnosis requires clinical MRI evidence of at least 2 characteristic neurological lesions that are separated in both time and space. That's the clinical maxim, and that speaks to location in the CNS. Treatment includes corticosteroids for acute exacerbations, immunomodulatory drugs to prevent exacerbations, and supportive measures. Okay, my friends, let's quickly talk about scripture. Right? In the book of Matthew, chapter 10, verse 29 to 31, Jesus said, "Are not 2 sparrows sold for a penny? Yet not one of them will fall to the ground outside of your Father's care. And even the very hairs of your head are all numbered. So don't be afraid. You are worth more than many sparrows. That is so reassuring. The book of Isaiah 43 verse 1 to 2, God says, do not fear, for I have redeemed you. I have summoned you by name. You are mine. When you pass through the waters, I will be with you. When you pass through the rivers, they will not sweep over you. When you walk through the fire, you will not be burned. The flames will not set you ablaze. We tend to always be anxious and afraid because of circumstances in life. But I want to encourage you, my friend, right? Regardless of whatever you're going through, put your trust in the Lord and He will see you through. If you look at the birds of the air and the flowers of the field, God makes provision for them, and you, my friend, are much more valuable in His sight. He will undertake for you. Just yield yourself to Jesus and the power of the Holy Spirit and watch Him work and intervene for you in your situation. Okay, here are my references, guys. You can catch me on Facebook. Just search for Internal Medicine Algorithms and Mnemonics. I'm also on TikTok and I'm also on Instagram as well. God bless you. Thanks for joining me. If you enjoyed this video, I strongly encourage you to smash that subscribe button, to like and share this video. Thank you so much. We've got some exciting topics coming up. The next one, God willing, we're going to cover is on hemochromatosis and Wilson's disease. I've got celiac disease lined up. Exciting, exciting times, guys. Go have yourself a wonderful day and I'll see you soon.